Em xin phép được dịch câu trả lời vừa rồi của thầy YeoSN ạ. So I want to translate your answer in case of if anybody didn't understand. Bác sĩ vừa rồi ông Nguyễn Duy Phương hỏi là thầy có kinh nghiệm gì về làm cái nội soi ngoài màng cứng hay là gỡ dính ngoài màng cứng hay không ạ? Cái đó thủ thuật rất là mới ở Việt Nam, em không biết có trung tâm nào ở Việt Nam mình đã tiến hành hay chưa. Thì bác sĩ muốn hỏi về cái kinh nghiệm của thầy Gieo. Thì thầy Gieo trả lời là khi chúng ta làm cái thủ thuật gỡ dính ngoài màng cứng á, hoặc là nội soi ngoài màng cứng á, thì nó sẽ chỉ định dành cho cái fallback surgery syndrome, cái phẫu thuật thất bại mà thôi. Chúng ta phải rất là cẩn thận khi chúng ta tiến hành gỡ dính ngoài màng cứng. Thì thầy nói rất là nhiều ý cũng như rất là nhiều kinh nghiệm của thầy, em xin tóm tắt gọn lại. Đó là chúng ta phải cẩn thận về cái compartment syndrome, về cái hội chứng chèn ép khoang. Chúng ta phải xem xét đúng cái chỉ định khi chúng ta thực hiện thủ thuật đó. Giả sử như là chúng ta không phải là bị cái đau lưng do cái phẫu thuật thắt lưng thất bại, hoặc là cho dù bệnh nhân có phẫu thuật thắt lưng thất bại đi chăng nữa, nhưng một bệnh nhân đau hiện tại là do cái khối thoát vị khác lớn hơn chèn vào, thì lúc đó chúng ta sẽ làm này sẽ rất là nguy hiểm, nguy cơ gây liệt sẽ rất là cao.
Thank you for your nice presentation about the interventional procedure. I'm an anesthesiologist and I do a lot of interventional procedure, and I'm totally agree with you that in the interventional pain management we must do no harm first. And related to the safety in pain management, especially in the neuroarterial intervention, I have some question. First, nowadays, as an anesthesiologist, we seen ultrasound worldwide, okay? Ultrasound especially for the surgical nerve root intervention. So how about your idea that is abandoned or continue? The first question. The second question related to the set triangle that we use to intervene in the transformational epidural injection. Nowadays, there are a lot of ideas suggest that the set triangle is not safe anymore, and they choose the crumbing triangle instead of set triangle, because the set triangle, in fact, there is a lot of blood supply for spinal cord. The third question related to the particle steroid. Nowadays, I just updated yesterday night. They said that probably it's not real cause of spinal cord infection, particular. In fact, that related to the vessel injury, especially the vessel to supply blood for the spinal cord. So instead, better to avoid the traditional shape triangle. We choose a crumbing triangle on the lower part of the foramen. It's probably the best solution to avoid the complication. Thank you.
This is a very useful and practical question for someone who does intervention. And if you do interventions, you will have thought through this as well. Conventionally, the triangle that is used to avoid the injury to the nerve, to avoid the injury to the blood vessels, have been discussed in multiple times. It really depends on the anatomy. For most cases, the triangle that you use really should, number one, avoid the nerve directly, number two, avoid the blood vessel directly. How do you know you're in blood vessel? Even if you use a CT scan, you can't be sure, because a CT scan doesn't see blood vessel. And if you want to use the digital subtraction angiography, you can do DSA. You can also consider when you were to put in the needle, as you hit the bone, as you walk off, are you able to appreciate that your needle is already posterior, anterior, or you're already too anterior? Now, when you give it at the inferior triangle, the problem is that that's also the trajectory of the nerve root. It's very hard to be sure, in a case of protruding disc, where is the nerve root? It's very hard. The nerve root can be just inferior, it can be inferior medial, it can be inferior lateral. Actually, the most important thing is when you get there, the first point of contact should be bone. After bone, as you walk anteriorly, you must appreciate that there's a slight give, and that give must let you know that it's time to give your contrast. And when you give your contrast, or if you feel a lot of resistance, you're actually not necessarily at the nerve root, because most of the time it's the posterior ligament, the transverse ligament that is in the way. Then after which, when you pass that ligament and when you give the contrast, you can see a very beautiful flow of the contrast, flowing up, down, and medial laterally. Now, you can give it inferior to the nerve root, that's no problem. But when you do that, it doesn't save us from being safe. I don't think there's a safe triangle per se. That's just for maybe good discussion, or maybe there's just a theory for it. But to me, I feel that there's really, in such cases, when patients come to us, their anatomy is never so beautiful. Never the textbook kind of anatomy. The anatomy is always compressed disc, reduced height, protruding, extruding. Patient is 80 years old, patient is big size, patient is scoliotic, and there's never going to be a quite properly a safe triangle. The safest triangle is really about you appreciating bone is friend, the rest of the structures are not that friendly. Be very careful when you go in there. Don't just go straight down. Check AP, check oblique, check lateral. Once you pass the bone, start checking. If you check, you're quite confident, not on the nerve root, the patient is mildly sedated, you're not possible to hit the nerve root without a reaction. You know, when patients respond with pain, don't push any further. Always push back, come at a different direction, maybe go inferior, then you can try. And if you find that it's so tight, it's so difficult to get there, every time when you get there, the patient starts a reaction. First, do not inject. Don't inject. If you touch the nerve, the patient can react. But if you touch the nerve and you inject, you are pushing drug right into the nerve. You paralyze the patient. So don't do that. So the important thing is there's a reaction. The first thing is pull back. You can even consider using the transcaudal approach, pass the catheter from below up. I can even pass retrograde to go to the anterolateral recess. Don't push too hard at the level where you think is unsafe. It's safe because it's in your hands, you know what you're doing. It's never safe triangle, it's always safe in hands. Okay, that's my advice. The second thing about particulate steroid, till today we don't really know for sure, but we have to be careful because the FDA closed claim study in a very nicely published clear paper have already said this is the advisory for now under the consensus of all the major society, major organization to come up with that guideline. Until such time the guideline change, I'll be careful not to use particulate steroids whenever I give any of this nerve root or epidural injection. I will be careful not to, because even if it's not due to the particulate steroid you don't know and there's no way to prove, I won't go against the guideline, because in the law, in the court of law, the guidelines is law. Until the law is changed, don't challenge it. That's my advice. Okay, I want to see all of us around and have a good time. And the problem about this, why patient get paralyzed or patient get weakened, or why is blood vessels being damaged, again, I think it's due to trauma, and probably also maybe a spasm, vasospasm. Sometimes there's no trauma, but it's just the drug giving it to it or into the blood circulation, and it might trigger off an occlusion or a trauma. So the key thing is appreciate that the needle is small, but you can cause harm. Patient react to tell us, we respect it. I've been to a few centers in the world, whether it's in Europe, America, China, and I've seen the patient jump, or even in Korea. The first reaction I say, don't go in anymore. Don't push anymore. Check your position, check your position, check your position. If the patient jump when you're still in the muscle, that's no problem. You just give more local anesthetic. But if the patient jump and you're already past the bone, don't inject. Pull back the needle, find another position. Because that's the final warning. Okay? Thank you very much. Thank you.